Now in Egypt, 10 degrees. Bismillah ar-Rahman ar-Rahim. Is it clear, Dr. Muhammad?
Yes, sir. Yes, sir.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Hi, everyone. It's nice to meet you tonight. This is a nice, short, straightforward topic talking about diaphyseal femoral shaft fractures. This is my disclosure about using some slides from the internet and photos. I want to start by taking your voting. We have here about 70 attendees. I want your voting on this X-ray. This 6-year-old child presented 5 weeks post-fracture with healing fracture mid-femur with shortening of 4 centimeters and anterior angulation of 33 degrees. Do you prefer to continue in conservative treatment, or do you want to operate on him to end the problem of shortening and angulation? I want your voting, please, and it will be recorded. If you want to conserve, just write 1C for conservative or 1O for operative. Okay? Our friend Dr. Hussam will collect your voting. The second is also for voting. This child presented 4 weeks post-fracture. He is 5 years old. This is segmental femoral shaft fracture in the spica with complete off ending at the proximal end of the fracture with shortening of 5 centimeters and no starting union at the proximal or distal end of the segmental fracture. I also need your voting. Just write 2C for conservative, continue casting, or 2O for operative, if you want to operate on him. So this is 2 slides for voting, please, and we will collect your opinion. Till you vote, I want to advise you to have a hug with koala, but don't try to have a hug with a kangaroo. It will kick you. Hugging koala is safe than kangaroos. Okay, Dr. Muhammad?
Yes, sir. Dr. Muhammad Al-Adi, would you please collect the results of the voting?
Yes, and after
Yes, sir, the majority go for...
Majority for what?
Yes, Dr.
Conservative treatment in case number 1.
Conservative case number 1?
Yes.
And for case number 2? You can
Waiting
continue,
with...
take your time. I need your
okay,
answer
sir.
After about 10 slides. I don't need your answer now. You can continue, slowly collecting your data, okay? Thank you. You may know that in our Middle East, about 50% of population are less than 20 years. This means we have a lot of children in our population. Pediatric fractures are different from adult fractures. It also varies in various age groups. As an example, for this humerus in infants, you usually have shaft fractures. In childhood, we have supracondylar fractures. And in adolescence, we have epiphyseal injuries usually. Statistics say that about 40% of boys and 25% of girls are expected to have a fracture during their childhood, with a big incidence at the age of 13. Femoral shaft fractures account for about 5% of all pediatric fractures. It differs from adult fractures in that the ends of long bones have thick cartilage, which is not seen on X-rays. The thick periosteum with good blood supply heals well and quickly. The more elastic, more cancellous bone leads to incomplete fractures and simple fracture patterns. The presence of the growth plate helps in good remodeling and having also special growth plate injuries. In this diagram, as we see, to remind you that thick joint cartilage, not imaged by X-ray, thick periosteum, rapid healing, collagen, easy fracturability, more cancellous bone, simple fracture patterns. The presence of the growth plate helps remodeling. And as you know, ligaments are stronger than bone in children. So usually bone fails first. It is a rare event to have ligamentous injury in the children. We usually have bone injuries. We have also specific fracture patterns for the children, which could be green stick, buckle fracture, deformation fractures, or physeal injury with their different types. As general rule, we can accept more angulation and displacement in the children because of better remodeling near the growth plates. As an example, this is distal radial fracture. The second X-ray on the right is after 1 month, and this is after 2 years. Excellent remodeling and length and alignment maintenance. But don't forget that rotational malalignment doesn't remodel. Treatment, it is very important to remember always that most pediatric fractures heal well, whatever you do. This includes also diaphyseal, femoral shaft fractures that heal well, whatever you do. Most fractures are treated non-surgically. This is important for diaphyseal femoral fractures. We have limited specific indications for surgery. For conservative treatment, it is including stable fractures, which may be incomplete, like a green stick, buckle, plastic deformation, or complete but stable fractures, which may be undisplaced or displaced but reducible. For operative treatment, it is for unstable fractures, which may be oblique or comminuted. Sometimes it is the preference of the patient or the surgeon. You overweight a child, difficult care of the patient, like mentally retarded patients, and some other special situations. Also, treatment of femoral shaft fractures depends on the patient's age, size, and type of fracture. Generally, small-sized patients, less than 2 years, usually do early spica. From 2 to 10 years, if we have overriding more than 2 centimeters, we do traction till appearance of callus, then later spica. If less than 2 centimeters, we can do early spica application. We can accept angular deformity of 30 degrees in the sagittal plane and 10 degrees in the frontal plane. Some surgeons can accept more angulations than these degrees. For older children, 10 to 15 years, open fractures, multiple injury fractures, external fixation should be considered, or flexible nailing. Other indications for operations are polytrauma patients, head trauma because of the early union, open fractures, associated neurovascular injury, and pathologic fractures. Generally speaking, we have specific complications for the femoral fractures. The most common is malunion. We can have also overgrowth, undergrowth, the reverse. Non-union is rare because of soft tissue interposition, distraction, or presence of a pathology. And infection is occasional. The potential complication of leg length discrepancy, that femoral shaft fractures can overgrow up to 2 centimeters in the first 2 years after fractures. But also the fracture can also heal and continue in the shortened position. This is two opposite situations. And we will explain later why we can have overgrowth and why we have shortening in other cases. This was a few years ago at UK at Sheffield. Back to management. Again, most fractures are treated non-surgical with specific indications for surgery. The conservative treatment is closed reduction and casting. This is still the commonest technique because of the good remodeling power we have for the femur, but it needs careful monitoring in the form of regular follow-ups, because when swelling subsides, the cast can be loosened or the fracture could be displaced, and you may need to remove the cast, remanipulate, and recast again. As an example, this child, 5 years old, with this hip spica, for 2 centimeter shortening, which will be compensated for the growth. As you see in the photo, this is a common technique to have the spica in the 90-90 position, not only for subtrochanteric but for diaphyseal fractures, because these positions facilitates hygiene and allows the patient to sit and to lie down on his back at the same time in an easy way. We have some casting problems. Generally, malalignment in the lower limb causes osteoarthritis, but this is common with tibial fractures. With the tibia, we have the knee, a modified hinge joint, we have the ankle, a hinge joint. These two joints can't tolerate the angulations, so osteoarthritis could be the result. But in the femoral fractures, because of the hip movement compensation, the ball and socket movement, the hip can compensate for a bigger degree of angular deformities for the femoral fractures, so it is rare to have osteoarthritis after femoral fractures. But the most common is loss of reduction in the form of overlap, shortening, and or angulations. Back to our slides. This is the first slide, case number 1. Can I have the voting result, please?
Attendees go for conservative treatment surgery.
Mostly for conservative.
Yes.
Good. How much conservative and how much operative?
Almost all of attendees see it's conservative treatment.
Excellent, excellent. In spite of 4 centimeters and 30 degrees, this is a patient after 3 years. Excellent alignment and remodeling, but 3.5 centimeters length shortening or discrepancy, with a small hint that this patient was using show lift immediately post-operative. Okay, take this point in your mind, please. For the second case, please, your voting result.
80% of the attendees see it's operative, need operative fixation or reduction. 20% see it's conservative.
Okay, we have operative and we have conservative also. Okay, this is a patient after 1.5 years. This is a patient after 3 years, but with only 1.3 centimeters shortening. And another hint from the patient, he didn't use any show lift. Take this in consideration again, please. With show lift, we have 3.5 centimeters discrepancy. With no show lift, less than 1/3 of the result, 1 centimeter discrepancy. That is why loss of reduction in the form of overlap, shortening, angulations is not important in femoral shaft fractures because the power of remodeling. Let us explain that more. We said that the growth plate can remodel deformity. We can accept angulations, displacement, because the epiphyses, when subjected to weight bearing, the ground reactive forces from below, the body weight from above, both will stimulate the physes to grow in an uneven pattern. The oblique physes, because of the angulation, will be stimulated to overgrow on the short side and undergrow on the long side to have a horizontal or transverse physeal lines to convert this to this. This is uneven growth that results from the combination of the ground reactive forces and the body weight. But don't forget again, rotational malalignment doesn't remodel. This is another example for the power of remodeling for this complete displaced with little shortening in a 9-year-old boy. This is after 2 months. This is after 15 months good remodeling. There is no discrepancy in length. This is the ASAMI meeting at Brisbane 2 years ago. After conservative treatment, let us talk shortly about surgical treatment, which could be in the form of K-wires, intramedullary nails, plates, or external fixators. K-wires are not common to be used in the femur. It needs additional casting could be applied percutaneously or open, but however, it is not common with diaphyseal femoral fractures. Elastic intramedullary nails are the commonest surgical technique used for unstable fractures in older children. It is a minimally invasive surgery, but it's very important to remember that to put it in the form of 3-point fixation, like this X-ray, not to have two ender nails or two K-wires or rush pins from one side of the bone. The 3-point fixation is very important in this technique. Plating could be used for overweight children or could be a parent's choice for difficult care with the Thomas traction. But we have the problem of larger scars than nailing, and it needs removal later. It could be done as a bridge plate or MIPO, minimally invasive plate osteocentesis, which could be introduced through small ones. Nailing. Some surgeons advocate nailing in older children with some problems with the epiphysis and apophysis. This is a matter of debate, which could be abolished by using the lateral or trochanteric entry point. However, it is still used by many surgeons in older children. At last, external fixation is mainly indicated for open fractures. Usually, simple monolateral frames are more than enough to treat such cases. This collected photos from several years from part of our orthopedic group in Benha during the yearly meeting organized with the Egyptian Orthopedic Association. These are in different years. It is done in Benha every year for more than 20 years now. It is a big clinical meeting. Please be aware that femoral fractures have a lot of problems. Bleeding. Don't forget that a femur can bleed more than 1 liter. 1 liter is a huge amount when compared to the volume of circulation of a child. So don't forget that bleeding should be treated urgently when you receive the patient. For conservative treatment, don't forget that you can have shortening or malunion. For operative treatment, you would need another surgery to remove the implants. Beware also of the non-accidental injuries, iatrogenic fractures, and pathologic fractures. Non-accidental injuries have a specific fracture pattern, usually transverse. When you have a child less than 1 year old with a transverse fracture, mostly this is non-accidental fracture. This is a matter of violence, which could be associated also with another signs of violence or specific patterns like corner fractures or bucket handle epiphyseal fractures associated with a femoral fracture, indicating that this is not a normal fracture, it is non-accidental injury. And examination of the child will reveal sometimes, and a silent child tells you the story of the non-accidental injury. Beware also of iatrogenic fractures. I am sorry to show that video for you. This is a child during physiotherapy. This video was taken by the mother. He was fractured, diaphyseal femoral shaft fracture during vigorous physiotherapy because of bad manipulation by the doctor in a child with CB.
The video is not worth مستمتعين. هو دكتور احمد بس كان عنده تكنيكال بروبلم، فاضل له 4 سلايدز. اتفضل يا دكتور احمد.
شير سكرين شغال معاك كويس كده؟
شغال حبيبي.
Sorry for this inconvenience. We were talking about diaphyseal femoral shaft fractures, and last slide we have talking about non-accidental iatrogenic fractures, pathologic fractures. Of course, pathologic fractures are another separate entity, and the video for iatrogenic fracture for a child with CB who was fractured during physiotherapy leading to diaphyseal shaft fracture. Final points. After treatment, we have 3 important points. Weight bearing. As usual in lower limb fractures, we start weight bearing when we have radiologic union in the X-ray, bridging, callus formation in at least 3 cortices in at least 2 planes of X-ray, and with clinical absence of pain and tenderness at the fracture site. When the child can start activity, after weight bearing, he can gradually start activity. This is patient adjusted according to the weight of the patient, the child, and according to the type of activity or athletic demands he will do. Lastly, the point we talk about, which is show lift and limbing. As we see in the X-rays, it is very important to allow the patient to limb post-fracture healing, to have more stimulation to the short limb by stimulating the epiphysis for further growth by the ground reactive forces and the body weight, to have compensation for the shortening in the future lengthening, as show lift will abolish this phenomenon. This is my dear friend Muhammad Ashab, just behind me in the first photo. It is 15 years ago in Japan at a SAMI meeting. You remember Dr. Muhammad and part of the Egyptian team at that time?
Yes, sir. I remember the samurai village.
Yeah. Okay. To conclude the treatment guidelines, for a child less than 6 months, any fracture pattern you have, any deformity, any angulation, just do early spica or even Pavlik harness. From 7 months to 5 years, if you have shortening from 2 to 3 centimeters, you can do immediate or early spica. More than 3 centimeters shortening, initial traction till callus formation in spica casting. If you have a polytrauma, multi-fractures or open fracture, you can do open reduction internal fixation with submuscular plates, flexible nails, or external fixation. From 6 to 11 years, with length stable fractures like transverse or oblique, you can do flexible intermedullary nails. Length unstable fracture, which is comminuted or very proximal or distal, open reduction internal fixation with submuscular plating, external fixation could be a choice. When we approach skeletal maturity, more than 11 years, for length stable fractures with average weight patients, flexible nails, length unstable with overweight patients, antegrade intermedullary nails with trochanteric or lateral starting point. We have, if we have length unstable with very proximal or distal fractures, open reduction with submuscular bridge plating. To take home message, don't forget that femoral fractures are not uncommon. They present about 5% of pediatric fractures. Femoral shaft fracture can bleed to up to 1 millimeter in a child. This is very serious. Conservative treatment is usually satisfactory. Conservative treatment is usually satisfactory. For the third time, conservative is usually satisfactory. Letting the child to limb is mostly beneficial. Surgery might be needed for good alignment and length maintenance. Thank you very much.
Thank you so much, Professor Ahmad Allam.